Welcome to our additional portion of our RAD 124 week. We're going to start out on the portable AP chest x-ray that we left off on yesterday. So when we are going to be positioning the portable AP chest x-ray, our patient is obviously going to be AP. We're going to try and get them sitting upright as much as possible in the bed, and we're wanting their mid-coronal plane to be parallel. Oh, let's change colors here. Parallel to the image receptor. That would mean our mid-coronal plane tilt, we would want to make equidistant, our mid-coronal plane equidistant to the image receptor. Our mid-sagittal plane should be perpendicular to our image receptor with a no mid-sagittal plane tilt, meaning that the long axis of the mid-sagittal plane should be perpendicular and in line with the long axis of the image receptor. Shoulder and arm position. Just because you're doing a portable doesn't mean that you can't practice good shoulder and arm position. You want to make sure that you're rolling those patient shoulders forward. So we're going to roll here. Sorry about the writing. Head position is especially important on these portable chest x-rays because many chest x-ray have been taken with a chin right in the middle of the upper thorax. So we need to make sure that that head is elevated and keep the chin out of the region of the IR. And then we're going to do typical breathing technique. We'll have them take suspended inspiration on their second breath. IR placement, as we discussed in class yesterday, we want to make sure that we have IR placement superior to the shoulders and that we are going to reach around the sides of the patient's ribs and ensure that we have that patient centered to the image receptor and that all anatomy is going to be included on that image receptor. Our central ray and positioning and angulation. This is probably the trickiest part. We started to talk about it a little bit yesterday, but you want to make sure that your central ray is kind of an average angle to balance out the slight difference between if this is the IR and this is the patient's chest. It's going to be really difficult to get a good angle that's going to be perpendicular to both. So what you would do is not necessarily go perpendicular to the chest, don't go perpendicular to the IR. You're going to kind of split the difference to get your central ray angulation. If you over angle, we'll see what happens. If you under angle, it's a different problem. So we just want to make sure that we're trying to learn to get the perfect angle, and that is going to be some trial and error for sure. When you evaluate the AP portable chest x-ray, I'm going to let you guys run through this yourself. As far as, I'll give you about 1 minute to go ahead and review this slide, fill in your answers, and then we're going to go through and we're going to look at how you did when we see what the actual criteria is. So go ahead and feel free to pause the slideshow if you feel like I went too quickly through that, but I don't want to make you wait on me. So when we get to the actual evaluation criteria that's stated in our book, we see that our mid-coronal plane, if we're truly parallel, should have no rotation. And we will identify whether there's rotation or not by evaluating the vertebral column and making sure that that column is equidistant from the sternoclavicular ends. So if you're looking closely here, here's one sternoclavicular end, here's the other. This patient is obviously rotated. So if you want to take your hands, put them on your SC joints, and if that right SC joint is away from the vertebra, that would indicate that this patient is rotated right side down. And you'll find as you rotate your body into an RPO, you'll feel how that SC joint moves away from your thoracic spine. The other thing that's going to indicate that there's no rotation is that we should have posterior ribs that are equal in length. This is only true if your patient doesn't have any scoliosis, so remember that that can be a variability. The other one I like here that's not on this slide is that the spinous processes, from what you can see, are centered to the vertebra, and you can see that they actually, this is a little bit underpenetrated, so it's difficult to tell, but if we had a better image, we'd be able to evaluate that. Now we're going to look at more mid-coronal tilt. This is a huge one on our portable AP chest x-rays. So we want to see the manubrium at the inferior to the fourth thoracic vertebra. So you can count your vertebrae by first identifying the first rib. So here I see this is the first rib. So here's my first, second, third, and fourth vertebra. So if I look at that, I can tell that it looks like that manubrium is above the fourth vertebra, which if my patient is in AP position, it means that the upper part of their mid-coronal plane is going to be tilted posteriorly. The other thing that we talked about yesterday, that's a great indicator, is looking for that 1-inch space between the apex of the lung and the clavicle, and it looks like we have less than 1 inch here, which supports that finding that we made regarding the manubrium being above the fourth vertebra. If there is tilt, we also see posterior ribs appearing more vertical rather than horizontal, and so that can further support that there is some tilt on this one. Mid-sagittal plane, we really evaluated for rotation when we evaluated the mid-coronal rotation. So again, you're looking at sternoclavicular joints equidistant from the vertebral bodies, and you're going to evaluate the spinous processes centered to the vertebra. When we look at the mid-sagittal plane tilt, this patient is actually pretty good because what we are looking for is we want to see that there's alignment. The long axis of the patient is going to be aligned to the long axis of the image receptor. Now, the central ray angle is really going to follow the same guidelines as the mid-sagittal tilt, or excuse me, mid-coronal tilting. So if I'm seeing an error in some of the criteria for tilting, I have to ask myself if my patient was actually tilted or did I have an incorrect central ray angle. So when I'm looking at evaluating for angle selection, I'm going to again look and see that the manubrium is superior to T4. I'm going to check and make sure that there's about 1 inch lung field above the clavicles, and I'm going to make sure that those posterior ribs still look relatively horizontal. If our patient did follow the rule or followed the suggestion and we had them roll their shoulders forward, then we should see scapula outside of the image of the lung field. And unfortunately, this patient does not have their shoulders rolled forward because their scapula is right there. Now, we know that most of the time on an AP chest x-ray that we are not going to get as good of a suspended inspiration. And so if you're getting up to 9 posterior ribs, they consider that acceptable on your portable, whereas we want 10 on your PA and 11 on your lateral. Now, if the patient's on a ventilator and that ventilator has limited pressure during inspiration, then you may never be able to get that full 9. So let's practice a couple here really quick. So number 1, we're going to go over the non-negotiables. So first of all is all the anatomy here. I'm going to take a quick look at all of my global view, and I have tops of my apices all the way down to the costophrenic angles, so I feel like all the anatomy is there. Secondly, we're going to look at my legalities. So if this were to not be an anonymized image, I can see is my patient name there, date of birth, time, and facility and ordering physician there. I do see that there is an error. There's a letter marker on here. It looks like they put the wrong lead marker on and they tried to cover it up with a digital marker. So that's one of those that we already discussed, lead marker considerations. So our next thing is, let's go ahead and say we're going to go ahead and approve this to go on to the next step. So now we're going to start looking at our technique. So do I have good bony trabecular pattern, soft tissue detail, cortical outlines? And I would say in this particular case, I'm lacking penetration. I am not getting any cortical detail of the thoracic spine. I have excessive brightness. I have a pretty good grayscale, but to me, this looks like I have an issue with penetration. So I'm going to increase my KVP 15% and probably repeat this image. But before I repeat the image, I want to make sure that there's nothing else that I need to change. So I'm going to go through the rest of my evaluation criteria. So the first thing I'm going to look at is my patient's mid-coronal plane parallel to the image receptor? And when I look at this particular image, I see here is an SC joint, here is an SC joint. So this patient is rotated. The patient is rotated with the gap between their right SC joint and the vertebra. So this would indicate that they are rotated into an RPO, moving that SC joint away from the vertebra. The other thing I can look at is see if I had better penetration here. I could evaluate the spinous processes within the thoracic vertebra, but because of the limited penetration, I just really can't tell. Over here, I can see that my lung fields are relatively close to symmetric, so I'm going to use that SC joint indicator as my most sensitive evaluator. Secondly, I'm going to look at my mid-coronal plane for tilting. So quickly, I'm going to go up to the apex, estimate the distance between apex and clavicle. I'm probably close to an inch here. So the coronal tilting is probably pretty accurate, but let's go ahead and check our manubrium. So we've got 1, 2, 3, 4. Here's our fourth thoracic vertebra. I can see the manubrium just superior to that, so that positioning is pretty decent. So for this image, if I can, mid-sagittal plane rotation that follows with our SC relationship to the spinal column. So we've already evaluated that, but when I look at mid-sagittal tilting, I'm going to be looking at the long axis here. Our patient is pretty much in alignment with the long axis of the IR, so that looks good. So really for this, if I could window and level and make that image demonstrate a little bit better penetration, or especially if my exposure index was within range, I'd probably go ahead and approve this image. If my exposure index was out of range or I couldn't get a better look through some of that denser tissue, then we would go ahead and repeat. Now this next image, the quality of this next image is going to depend a little bit upon the purpose of the image itself. Now, if this image was, you can see here that this patient has an endotracheal tube. So here is our endotracheal tube. We're watching it come down. It's going to end about right here. If the whole purpose of this image was to identify ET tube placement and the patient was otherwise having their chest x-rays done separately, I might approve this one for endotracheal placement. However, if this was for a series or, a true evaluation of the chest, we can see right off the bat that it's not going to pass the test. So here I have, as soon as I start to do my global view, I'm missing, I have apices, but I am missing costophrenic angles. So right there, I have clipped anatomy. Number 2, I want to make sure that I have good, that the legalities are all there. Right here, we see that we have a digital marker. However, the patient did include some details that are important, but here it doesn't meet the legality qualities because of that digital marker. We'd also have to evaluate and make sure the patient name, date of birth, facility, date, and time were on the image as well. If we looked at all of that, we know we're probably going to repeat this unless it's just for ET2 placement. So now I have to evaluate the patient. So first thing I'm going to look at is my mid-coronal rotation, and you can see here's an SC joint to vertebra distance. Here is our other SC joint, so we see that they are not equidistant to the vertebra. Again, this is the right side SC joint is away from the vertebra, indicating that that patient, again, was in an RPO position. So we know that we have some mid-coronal rotation. I can also kind of track a little bit better on this one, those spinous processes. They do look relatively centered, but so my SC joint evaluation is going to be a little bit more sensitive. When I look at my mid-coronal tilt, here I'm going to first go right up to the apexes, evaluate the distance between the apex and the clavicle. This looks significantly over an inch, so that would tell me that that one of two things is wrong. Either my patient is tilted anteriorly, or my central ray angulation is directed too far caudally, throwing those clavicles inferior in the image. The next thing I'm going to look about is my mid-sagittal rotation, which we already evaluated, so we can jump right into our mid-sagittal tilt. The patient is, as you can see, not in alignment with the image receptor, so they are slightly tilted. So again, I look for technique as well. This has a nice long grayscale. I see soft tissue detail. I see bony trabecular pattern. I can identify good lung markings. So the contrast on this is really good. The penetration is good. I'm able to penetrate the radiopacities of all the patient's lines and tubes. So that is very helpful. So ultimately, I'd have to make the final decision based off of that clipped anatomy. If I felt like it was just for ET2 placement, I would probably proceed with this exam. If it was for a regular evaluation, then I would need to repeat it based upon clipped anatomy. Okay, some interesting other positioning considerations. We mentioned on our patients that are very kyphotic, you might look at them and think, well, why don't they stand up straight? Or I'm going to have them stand up straight. And the problem is they just really cannot do it. So especially in our older years, a lot of us with poorer bone density are going to become more and more kyphotic. And when they do that, you might see a patient's head right down where in their chest. So when we take their x-ray images, you're going to get chins right in their chest field. So for these patients, the only way that you can really avoid this is if I have a patient, say in suite, and they are very kyphotic, what I can do is actually try to angle cephalically a little bit to match their kyphosis, and that will help produce a more elongated, normal appearing image. So for this, you're usually going to have to put your patient in an AP projection and then angle so that you, again, are splitting the difference between the image receptor and the patient's mid-coronal plane. So when you have a kyphotic patient, and then you are going to go ahead and you're noticing that the manubrium is below T4, or that there's large distances between the apices and the clavicle, you can add that cephalic angle to kind of throw that anatomy up to where you would regularly see it on an image. The other thing that you can do is basically have the patient in an AP projection. So here's my patient from the side in an AP projection. And usually if this is my bucky, I would have them scoot right up to the bucky. But in this case, what you can do is have that patient sit in a chair and then pull the chair away from the bucky and have them lean back, which will help overcome some of that kyphosis, if you can see there. So those are a couple different ideas to complete with your kyphotic patients. Patients that are supine and can't be moved, due to the gravity and the weight of the anterior chest, the chest is going to move superiorly, which is going to push the clavicle superiorly. So if that is the case, you're going to need to utilize your angle. Add a little bit of an extra caudal angle to shoot those clavicles down. Okay, technical factors, these are going to be the same as they were for our other chest x-rays. We want to make sure that we have good enough penetration and a long enough grayscale to see our lung markings. We want to have the penetration to get through the diaphragm. We want to have the penetration to demonstrate the heart borders, the hilum, the greater vessels, and then we want to have both penetration, contrast, and adequate intensity to be able to demonstrate the bony cortical outlines as they are defined. We know that we need to have a longer scale of contrast, which is going to allow for a greater contrast resolution. And we want that contrast resolution to demonstrate vertebra, mediastinal structures, lung markings, air fluid levels, and any other internal tubes, lines, etc. We want to look at our technique and make sure that there's no quantum model noted and that there's minimal scatter. And we're going to know that we're going to reduce that scatter by using a grid. Okay. And then finally, here are those image evaluation musts, or those legalities that have to be on the image. Make sure patient name, facility, identifier, date and time, as well as a lead marker is on the image. Okay, so we talked about some of the things that we are looking at on our portable chests. We practice with these a little bit. If we put it all together, you find this massive list of things that we're looking for. But let's just break down and make sure that we've already talked about all of these. So if I'm looking at the thoracic vertebra and posterior ribs faintly seen through the mediastinal structures, that tells me that I have adequate penetration. When I'm looking at the date, time, SID, patient position, etc., that's telling me that the legalities or the non-negotiables are there. If I'm looking at symmetric lung fields, that tells me that my mid-coronal plane is going to be parallel to the image receptor. If we're looking at the clavicles or the SC joints being equidistant for the vertebral columns, that's also supporting that my midcoronal plane is parallel. If there's no foreshortening or elongation, that would indicate that my midcoronal plane was not tilted, that it was equidistant from the IR. If the manubrium superimposes T4, that indicates that they were equidistant from the IR. If I see 1 inch of lung visualized above the clavicles, that means my patient had a good midcoronal tilt. There was no tilting. They were, again, equidistant to the IR. If the mandible is not visualized, that indicates the patient's chin was elevated out of the way, like it was supposed to be. If the clavicles are in the same horizontal plane, that would indicate that my patient has no mid-sagittal plane tilting. If the scapula are out of superimposition with the lungs, that would indicate that my patient adequately rotated their shoulders forward. If T7 is centered to the image, that would mean my central ray was accurately placed. If both lungs are seen in their entirety, that means I didn't click Binney anatomy and I utilized good IR and CR placement. If I have 9 posterior ribs visualized, that means I had adequate inspiration. And then again, of course, no artifacts and all the legalities are present. No quantum model, good contrast, good penetration, good intensity. So that list just goes to support what you guys have already predicted. So since we already did a couple of these, I'm going to go do a quick evaluation of just this one on our right. So first thing we're going to start with is we're looking for anatomy. So I'm doing a global view. I have apex, costophrenic angle, and apex. So all my anatomy is there. Number 2, I'm going to look at my legalities. So patient name, facility name, date of birth or MR number, date and time of the exam. And we're going to assume that since this is an anonymized image, that those things were there. We're looking for our lead marker, which is not present on this. So that's a whole nother consideration we need to take into account. Third, we're going to go ahead and evaluate our technique to see if this is even adequate to consider much further. So if I look here, I'm looking for soft tissue detail, bony trabecular pattern, and good tissue penetration. So here I do see that I have tissue penetration through the thickest part here in the mediastinum, where we see the heart overlapping the T-spine. I like my grayscale. I have good soft tissue detail. We're seeing good lung markings, so that means I have an adequate grayscale. It does look a little bit bright to me. That is something that maybe would be able to window and level out. So I would pay very particular attention to my exposure index to see how much more we could optimize this image. So that would help me decide the next step. Now let's go ahead and assume that our exposure index is adequate, so we have some window and level capabilities. Now we're going to go ahead and start looking at the more fine details. So here I'm going to start with my midcoronal rotation. I am very obviously rotated on this patient. Here's an SC joint, here's an SC joint, and the spine is way this direction. Again, I have a increased distance on my right SC joints from my vertebra, indicating that my patient was in an RPO projection. Beyond that, I'm going to go ahead and continue my evaluation. I would typically look and see if my spinous processes, since I do have relatively good penetration here, my spinous processes are to my patient's left, which would support that that patient is in an RPO projection. So based off of this, I'd say this is repeatable. This is a really significant rotation. It needs to be repeated, but I want to see when I go to do this repeat, do I need to correct anything else? So I'm going to go ahead and go to my midcoronal tilt. So I'm looking from my apex to my clavicle, apex to my clavicle. It's about 1 inch. So my midcoronal tilt along with my central ray angulation is going to be pretty accurate here. So that midcoronal is relatively decent. My central ray angulation is relatively distant. I really just need to get in there and manipulate my patient's midcoronal plane. Next, we're going to look at their mid-sagittal rotation, which we already technically evaluated when we looked at that midcoronal rotation. So now we're going to look at our mid-sagittal tilting. Here you see that the patient is very tilted. So you can tell that their head is turned towards their right, probably affecting some of that body tilt. So when I go to repeat this exam, I'm going to have my patient put their chin up and face straight up if at all possible. If I go look at the scapula here, I can see that the patient's scapula does superimpose the lung field. So we need to make sure that we're rolling that patient's shoulders forward on our repeat image. And then thirdly, we have very limited number of ribs visualized. So we have 1, 2, 3, 4, 5, 6, not even a completely 7 ribs visualized in the posterior lung field. So we would need a much better inspiration on our repeat. Okay, hopefully that gets you ready to go on your AP portable projections. Now we're going to talk quickly about a lateral decubitus chest x-ray. Now really our evaluation criteria on these is really going to be the same as it was for the PA and for the AP portable. The only thing that special considerations we're having here is that the arms are a little bit more tricky to position. And then secondly, we're really looking for good positioning in that we are positioning according to where we are trying to see air and fluid levels. So obviously we know with fluid, it's going to go to the most dependent area. Air is going to go to the most superficial area. So when you're looking for free air, you want the affected side up. When you're looking for fluid, you want the affected side down. The other thing you have to consider with this is if you lay that patient directly on the table, you are going to end up clipping the ribs of the side down and possibly the lungs. So make sure when you're doing a decubitus that you are positioning them on top of a sponge so that there's enough room that you're going to get their entire thoracic cavity on the image receptor. Patients should sit in a decubitus position for, some recommend 20 minutes, but 5 minutes at a minimum to give time for those air fluid levels to settle. So when we are positioning our patients for a decubitus chest, we can either do it in AP or PA. Either one is acceptable. We want the mid-coronal plane parallel to our IR. We want no mid-coronal plane tilt, meaning that we have a mid-coronal plane that is equidistant to the IR down the whole plane. We want a mid-sagittal plane that's not rotated but is perpendicular to our IR, and a mid-sagittal plane that has no tilt and is in the same long axis as our IR. Again, here you need to have this little bit extra consideration. You need to try and get those shoulders elevated so that you're not going to end up with an arm under your patient's ribs. So arm and shoulders are going to be elevated, and once they have them up and elevated, you can try to have them roll their shoulders forward, but that can be challenging. Head position, the patient's head needs to be elevated with chin up to keep their chin from appearing within the image. Breathing technique, like all of our other chests, are going to be suspended inspiration on the second breath. Image receptor placement is going to be about 1 inch above the shoulders, and then we'll have to verify that both lateral aspects of both sets of ribs are within the image receptor field. And then our CR positioning, this should be in the decubitus position. This is usually a little bit easier that we can just shoot perpendicular to our image receptor. So that patient, the special considerations that we had with the patient position for a portable chest x-ray, while they still exist, they're not quite as difficult to work with on these. Okay, so we talked about how this can be done PA or AP. If it's done PA, that is going to help us see that that's going to cause us to see the intervertebral disc space is a little bit distorted, whereas in AP it will not. When we're looking at how we did for our mid-coronal plane rotation, we're going to again assess those SC joints being equidistant from the vertebral column, making sure that the ribs are symmetric, and then making sure that if we can see those spinous processes, that they are centered to the vertebra. When we look at the mid-coronal tilt, again, we're going to be using that manubrium over T4, as well as our apices of the lungs to the clavicle, measuring about 1 inch to determine if we have good mid-coronal plane tilt or if we have good central ray angulation. If the clavicles are high or the manubrium is above T4, that would indicate that the patient's shoulders were tilted posteriorly towards the IR if they were in AP projection, or if they were in PA projection, that would indicate that they were tilted anterior to the IR. In this, as I mentioned, you have to be very careful about getting those arms adequately elevated and out of the way so they're not appearing in the image. We also want to try and roll them forward, the shoulders forward, although that can be difficult. So we're going to make sure that we're going to try to see that the scapula are out of the superimposition of the lung field. And then we want to assess for proper inspiration. We're going to treat inspiration on these decubitus like a portable. So now we're going to, again, look for 9 posterior ribs. Okay, so we kind of already talked about how we're going to evaluate the decubitus chest. You can kind of take a minute to look this over, fill in your blanks, and then what we're going to do is come back and see how correct you were. So when we put it all together for our decubitus chest x-ray, we want to see that thoracic vertebra and posterior ribs are seen through the heart and mediastinal structures. This tells us that we have adequate penetration. Our KVP was acceptable. We want to see an arrow or word marker that demonstrates the side up. So usually it will be an arrow, an up arrow on the upside, just to demonstrate how we position that patient. The lung field down should be demonstrated with no bed or pad superimposition. And we want to make sure that we see the entire rib cage line along with inside of the IR. We want to see a symmetrical lung field. That would indicate that we didn't have any mid-coronal rotation. We want to see clavicles equidistant to the vertebra. That indicates no mid-coronal rotation. We want to see posterior ribs equal in length. Again, mid-coronal rotation. We don't want to see any chest foreshortening. That would indicate that we had mid-coronal tilting. We want to see the arms out of the way, the scapula and the mandible all outside of the lung field. This means my patient's arms are elevated, their shoulders are rolled forward, and their chin is elevated. We want to see that the manubrium superimposes T4. That would indicate that I have no mid-coronal tilt and that I've utilized an adequate central right angle. I want to see that T7 is centered to the image. That would indicate good IR and central ray placement. I want to see both lungs visualized entirely because if all the anatomy isn't there, this is not an acceptable image. We need to see that 9 posterior ribs are visualized. That indicates my patient had adequate inspiration. And then, of course, we're going to add in our non-negotiables, including facility information, patient information, lead marker, adequate contrast, no quantum model, and then good delineation and penetration of anatomy. So here's a couple examples. So number 1, what we're going to do, we're going to go and we're going to see if all the anatomy is there. So a global view, I'm seeing apex to costophrenic to costophrenic to apex. It looks like both of these apices are slightly clipped in this case. Over here, I'm going to see apex to costophrenic to apex. All of my anatomy is on this one. So I know that we're going to have to repeat this one over here. We're good to go on this one at this point. So now I am going to ask myself about the legalities. So I'd be looking for an up arrow on both of these, which is missing. I'm going to look for a letter marker on both of these, which is missing. I am going to look for the patient name, facility, date of birth, time, and date of exam, which we'll assume is there. And then I'm going to tell myself I probably need to repeat this exam because of the missing letter markers and then the clipped anatomy. So this one needs to be repeated for sure. But let's go ahead and keep looking. So I want to look here and I want to evaluate my technique. So do I have good soft tissue detail, bony trabecular pattern, adequate lung markings, good penetration? And I can say I have reasonable lung markings. I definitely have some pretty good penetration. My grayscale might be a little bit short. I'd like to see a little bit more grays up in this area here. So what I might do is go ahead and increase my KVP and decrease my mass if I find that I do need to repeat this. But for now, if my EI value is within the appropriate range, then this can probably be windowed and leveled in. So next thing I'm going to look at is my mid-coronal rotation. So we're looking at our SC joints here and here. And really there's very minimal rotation, if any at all. If we look over here, we can see spinous processes are towards the side. They're towards, if this is my patient's right side, the spinous processes are actually towards that right side, meaning my patient was, if they were in AP projection, they were rotated slightly LPO. We can also kind of follow that up by looking at the lung fields do not look quite as symmetric side to side. Okay, so we have a little bit of mid-coronal plane rotation on this one. This one looks pretty good. Now we can look at our mid-sagittal plane is going to follow that mid-coronal plane rotation. Now we're going to look at our midcoronal tilt. Now, in this case, it's kind of like having a supine patient. They're going to probably have a little bit of midcoronal tilt just because of positional factors. But here, most of my, I'm going to usually evaluate my midcoronal tilt by seeing if the manubrium is over T4, and this manubrium happens to be over T1, T2, T2, and 3. So my manubrium is high. The clavicles are also high, which would indicate that the superior aspect of my patient was tilted back towards the IR. So because of that tilting, I would probably go ahead and repeat both of these images because you're seeing the same issue over on this side. When I did that, I'd obviously move my IR on this image up. I'd increase my KVP, I would decrease my mass, and I would reposition for this image. So now we're going to move on from our PA and AP chest projections and start looking at some oblique chests, and that is going to overlap with our oblique ribs. Now, most of the time, it's pretty rare to do an oblique chest, so most of these criteria you're going to be applying to the ribs more often than not. So whenever we're doing an oblique of the chest or ribs, we want to use a 45-degree obliquity. And the reason we do that is it's going to demonstrate the lung field, and it is going to superimpose the heart with the vertebral column. It's also helpful in that it allows for heart evaluation if we increase that obliquity up to 60 degrees. So it's going to be important. If you know you're looking at the ribs, you're going to go 45. If for some reason you're looking specifically at the heart shadow, you need to go 60. A 45-degree oblique would demonstrate twice as much lung field on one side as the other side of the vertebral column. And if you see that more than with this one, if you're looking more like a lateral chest, you know you've over-rotated. If you're looking more like an AP or a PA chest, you know you've under-rotated. So that's kind of my go-to. You can follow the rules as the slide says. If it's more than twice as much lung field on appears the patient was over-rotated. If it's less than twice as much, then they were under-rotated. But my key is, does it look more like a lateral or more like an AP? And then I make my decisions off of that. PA obliques are often preferred because it gets the cardiac OID reduced. And we know from your positioning class that RAO is basically equal to an LPO. So whatever I see on an RAO, I'm going to see on the LPO. It's just the area that's going to be magnified or away from the image receptor is going to be different. But these are really hard. Basically, they're the same image. And LAO is then going to be basically equal to an RPO. So if we're looking at just a general oblique chest, we could do this in PA or AP oblique. We know from rib considerations that plays a big role in determining whether we're going to do AP or PA. If a patient presents with anterior rib pain, we're going to do our obliques in PA. If they have a posterior rib pain, we're going to do them in AP. And if they have axial rib pain, we are going to be doing those in AP. So for our mid-coronal plane rotation for our oblique chest, unless it's for cardiac specifications, we're going to go at 45 degrees from parallel to the IR. One of the ways that this can actually be easier to do, I told you how it was difficult for me to just see a 45-degree midline. One of the tricks I was taught was that if you happen to have tile floors, if you point the patient's toes towards the corner of the tile, that will usually get them into a 45-degree oblique. With our mid-coronal plane, we still want to make sure that we don't have mid-coronal plane tilt. So in this case, we want them that mid-coronal plane to be vertical. It's a little bit harder to describe in this position, but we want them vertical and upright. Mid-sagittal plane rotation, if our mid-coronal is at 45, our mid-sagittal is at 45 as well. And then our mid-sagittal tilt, this is the one that would have the patient leaning toward or away from the board. And so we want to make sure that the mid-sagittal plane is equidistant from the image receptor. Shoulder and arm positions for this, you're going to have to elevate them out of the chest and lung field. Head position, the chin needs to be elevated. Breathing technique, we're going to utilize that second inspiration breath hold. IR placement, this can be variable depending on if you're looking at ribs above or below the diaphragm, but if we're just considering a general chest oblique, you'd maintain that IR placement about an inch above the patient's shoulders. If you're doing above the ribs, you're going to maintain that same placement. If you're doing below the ribs, you're going to put the bottom of your IR at the inferior costal margin. Your central ray positioning is going to be perpendicular to the IR, and you're going to have it aligned with your image receptor with a perpendicular or 90-degree perpendicular positioning, so you have no angulation. Okay, so I'm going to let you kind of read through this, and I want you to start developing your thoughts as to what an oblique chest is going to demonstrate for you. And now, before we go to the actual evaluation criteria, I want you to kind of think about some of the planes that you use for the rib imaging. So we know that we use the coronal plane. Our MCP is 45 degrees to the IR. How do we know if we got it right? Well, that's what you just worked on the left side. We know that if we got it right, there should be 2 times as much lung field on one side as the other. If we got it wrong, it's going to look more like a lateral chest. If we've over-rotated it, if we under-rotated it, it's going to be more like a PA chest. The mid-coronal plane has no tilt to the IR. This would mean that basically the long axis of the body is in line with the long axis of the image receptor. The heart and the lungs should demonstrate no foreshortening. The manubrium should be at about T4. And there should be about 1 inch of lung field above the clavicles. These should absolutely hold true if we're in AP projections. Other positioning considerations or requirements are that the arms and soft tissue must be elevated and away from the image receptor. So we would say that the arms would then be abducted. Respiration should be suspended respiration on the second breath. We know we've accomplished that if we get those 10 posterior ribs above the diaphragm. Technical factors are going to be really similar, so we need to make sure that we have adequate tissue penetration and adequate grayscale to see lung markings. We want to have the penetration to get through the diaphragm. We need to have that penetration to get through the heart borders, the hilum, the great vessels, and the bony cortical outlines. We need to make sure that there's enough contrast to demonstrate the vertebra, while not such a short scale that we wipe out some of our lung markings. We need to make sure that we have demonstrated air fluid levels, internal tubes, etc. There should be no quantum model and minimal scatter. We also must adhere to the legalities of all of our imaging studies. So if we put it all together, in this case, if we put it all together, since we're at 45 degrees now, we're no longer going to see those SC joints equidistant to the vertebra, but we should see them demonstrated without spinal superimposition. There should be 2 times as much lung field on one side of the vertebral column as the other. Those first 2 items on this list refer to the mid-coronal plane rotation. The manubrium should be superimposed on T4. If we have mid-sagittal plane tilting or mid-coronal plane tilting, that can affect that relationship of the manubrium and T4, which will also affect the relationship of that 1 inch of apical lung field superior to the clavicles. If we abducted those arms properly, we should see no arm or soft tissue overlap with the thorax. The right and left bronchi should be centered to the image. Both lungs should be included in their entirety if this is a true chest oblique. If this is a rib oblique, then we can collimate down to the lateral aspect of the vertebral side of the unaffected set of ribs. We want to see at least 10 ribs, posterior ribs superior to the diaphragm, indicating that we had adequate inspiration. Then all of our legalities, including facility information, patient name, date of birth or MR number, image exam, time and date, lead markers, and then adequate technique are all going to come into play. So if we look at these 2 images, I can look right off the bat at this image. If this is a true oblique chest, I see that all my anatomy is here. I've got apex to costophrenic angle to apex. So all the anatomy is included. I can check that one off my requirements. Secondarily, I wanted to check my technique. Do I have adequate tissue penetration? Do I have soft tissue detail, bony trabecular pattern, adequate lung markings apparent? And I would say that I am very limited on my penetration. There's very poor penetration through the diaphragm, very poor penetration through the mediastinum and the great vessels here. Grayscale looks acceptable, but I would definitely increase my mass, possibly my KVP and my mass according to what my exposure index was. But if all the legalities are there, I'm going to continue my investigation to kind of support. Right now I'm leaning towards repeating this exam, but I'm going to further my investigation to ensure that that's what I want to do. So I know this was an oblique chest, therefore I should see twice as much lung field on one side of the vertebral column as the other, and they look almost identical. That means that this patient is much closer to an AP or PA than they are to a lateral, indicating that this was an under-rotated oblique. So with that being said, this is a repeatable image, but I'm going to go ahead and see if I need to adjust anything else. Here I can count my ribs. I've got rib 1, 2, 3, and 4. That means this is my fourth vertebra right here, and then I can see my manubrium very close at the level of that fourth vertebra. So my mid-coronal plane is not terrible. However, if I come over here and I look at my apice to clavicular distance, that's going to be less than 1, so that would indicate that my patient is tilted posteriorly slightly, elevating that clavicle towards the apices. So when I correct my patient rotation, I am also going to correct their mid-coronal plane tilting. Mid-sagittal plane rotation, we pretty much covered with the mid-coronal. If I look at mid-sagittal plane tilt, really this mid-sagittal plane is nearly perpendicular. If it was truly rotated to 45 degrees, I would be looking to evaluating that clavicle to apical line as well as the manubrium to help me differentiate that. So this is definitely a repeat exam. Adjust the technique, rotate more, correct the mid-coronal tilt, and then I can get an acceptable image. Over here on this patient, it looks, just eyeballing it, it looks like they did a much better job. So if this is not ribs, but it's truly a oblique chest, I see apex to costophrenic to apex, all the anatomy is there. That's checked off. Secondarily, now I'm going to go through my technique. So I'm looking for soft tissue detail, bony trabecular pattern, and good cortical outline. I would say for this, I have a very long grayscale, almost excessive, and it looks like I have a little bit of a lacking penetration of the diaphragm. So I would increase my mass and my, I would look at my exposure index. If I was low on the index, then I would increase my mass and possibly my KVP. If I was adequate on my index, then I would probably decrease my KVP but increase my mass to get that additional density that we're missing here. So then I would check my patient legalities. They did a great job. They've got a good letter marker on here, thank goodness. I'm going to check my patient name, facility, patient ID number, or date of birth or MR number, exam time and date. If those are all on there, then we're going to proceed. Now I'm going to look at my mid-coronal rotation. Here I can find the lateral area of the vertebra, measure that distance over to the lateral area of the ribs, and that is going to be about twice the distance that I have on the opposite side. So 45 degrees looks like it's a pretty well positioned 45 degree oblique. Now I'm going to look for mid-coronal tilting. So my mid-coronal rotation is good at 45 degrees. That means my mid-sagittal rotation is good at 45 degrees. Now I'm going to follow this clavicle down, and I'm going to find the sternum, and the sternum manubrium is right here. So now I need to come up, and I see vertebra 1, 2, 3, and 4, and my manubrium is at about that fourth level. So I have good mid-coronal tilting here. So if my exposure index was at a good point, if I had window and level capabilities, and if we have 10 ribs, which I think 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We do have 10 ribs. I know my inspiration was adequate. I don't have any superimposition of the arms or chin, so I'm going to say that this is an acceptable image. Okay, pediatric chest considerations. So infants only have 1/8 the number of alveoli that adults do. Therefore, their lungs are going to be much denser and radio-opaque. They also have short, wide lungs, and that will change over time. So for optimal resolution, we need to choose the smallest IR that will work if you're using a CR system. If you're using a direct system where you just have a single imaging plate, then you're going to have to use that imaging plate. Make sure that you're collimating to reduce patient dose. Make sure you're using the highest kVp possible to reduce patient dose. If applicable, use radiation protection. And make sure, if you can, that the face of the baby is not looking toward one side or the other, because we know where the face turns, the rest of the body will follow. So what positioning planes are we using for a pediatric chest x-ray? These are the same as the adult, so we were going to fly through this. Mid-coronal is parallel. Mid-coronal plane tilt, we want the mid-coronal plane also equidistant so that we don't have any tilt. We want the mid-sagittal plane perpendicular. We want the mid-sagittal plane not tilting to one side or the other, but we want it in alignment with the long axis of the IR. Shoulders and arm positions, it would be fantastic if the pediatric patient is old enough to cooperate and can roll their shoulders forward. However, that is often not the case, especially with your neonates. Especially with infants, you might have to have somebody in the room to hold their arms down just to keep hands and arms out of the chest field. Head position, we want looking straight ahead, chin up. Again, somebody might have to hold that head in that position. Breathing technique, if they're old enough that they can follow breathing instructions, that's fantastic. You want to do suspended inspiration on the second breath. If they're too young to follow instructions, then you're just going to almost do like we talked about with an endotracheal or a ventilated patient, and you're going to expose at the maximum of their inspiration. Central placement, or excuse me, central ray placement needs to be to about T6, T7. Angulation should be perpendicular to the image receptor and the patient. IR placement should be about 1 inch above the shoulders. Make sure that you are collimating this down, so you're not doing a babygram. If you're looking for a chest x-ray, you want just the chest, apex through costophrenic angles. So I'm going to give you a moment to kind of predict what these evaluation criteria is going to be. Feel free to pause if I go too fast. Okay, so first thing we're going to look at is the mid-coronal plane. Did we get it right? So if we got our mid-coronal plane right, the same indications we used on our adult chest x-ray is going to help here. We're going to look for those SC joints equidistant to the vertebral bodies. We can look for spinous processes centered to the vertebra, and symmetric ribs. If my central ray is perpendicular to the IR, then that is going to have those same kinds of outcomes that we would see if we had a mid-coronal plane with no tilt. So if we have a good central ray perpendicularity with no mid-coronal tilt, we are going to see that that T4 corresponds to the manubrium, and that the apices are going to be less than an inch now because these are very small people. If we're finding that the superior and anterior ribs are corresponding to the posterior ribs, meaning that that they should be that superior anterior ribs should be superior to the posterior ribs because of the anatomic differences in a neonate and early pediatric versus an adult. So we should see those superimposing. So that would indicate that our angulation was appropriate and that we had the mid-coronal plane parallel to the image receptor. Other positioning considerations, you can elevate the chin slightly for a portable ETT so that the tube placement views so it doesn't superimpose the airway. Air is less bright than blood, pus, protein, and alveoli, so sometimes you will see almost like tracks where you can make out the trachea because of the density of neonate lungs. Time exposure for these are kept at a minimum because of the lack of control of motion. We know that we're not going to get the same kind of inspiration on these babies as we do adults, so we're looking for 8 posterior ribs for neonates, 9 posterior ribs for infants. We also know that inadequate inspiration makes the heart look wider and the lungs look brighter. So now we're not just having them try to expand their lung field, but it's also to tell if their lung field is normal radiopacity or not. So here's a couple little babies, and this is an example of one that you could be working with. These can be very intimidating. So obviously it mentioned that you might have to elevate this ET tube to get this artifact out of the chest x-ray. So you can see that this is mobile. If you have a nurse available to do that or a respiratory therapist, highly recommend that. So that could be shifted to the side or held during the exposure. If we look at this particular x-ray, we're going to go through all the requirements here really quickly. So here we see apex to costophrenic angle to apex. We have all the anatomy. We have soft tissue detail, bony trabecular pattern, and contrast. Our contrast is very, very low in this patient, so we might have to reduce the KVP or see if they could window and level it out to a more appropriate level if our exposure index is adequate. Obviously, legalities is going to be huge. Letter markers can be an introduction of pathology here. So if you're using a letter marker and you're using a bag, make sure that you're putting the letter marker inside the bag that covers the image receptor and the letter marker, so you're not introducing pathogens into these tiny babies. Okay, so if all of our legalities are there, we have a letter marker. Now we can start the evaluation. Here I can see that we're going to look for symmetry between both sides of the lungs, and it appears that this baby's right lungs are a little bit larger than the left. That would indicate that the spine has moved to the left, so that patient then would be in an LPO position, slightly rotated LPO. If we go up here and we look at these little bitty clavicles, here's the sternoclavicular end, here's the sternoclavicular end, and you can see again that it has been moved into an LPO position. So those two findings support one another. You also see that the baby's head is turned. That's probably contributing to more of this rotation. So by straightening out the baby's head, it might correct the problem. So if we look at midcoronal tilt, we would see that the anterior and the posterior ribs are superimposing. And so there is not a lot of midcoronal tilt here to be recognized. That would also indicate that our central ray angulation is appropriate. Mid-sagittal plane is relatively perpendicular. We already looked at the problems that we saw with the midcoronal. That applies to the mid-sagittal, and the mid-sagittal is not tilted. It is well in line with the image receptor. Now, you might look at this from more of a critical standpoint and say, oh, they should have collimated closer, and I can agree with you to a certain extent on that. However, if you are running the risk of a baby moving or something like that, and you don't want to cut it so tight that any sort of adjustment would cause anatomy to move out of the image. So they did a reasonable job here with collimation. So if I looked at this image, it would depend on the purpose of the image whether I repeated this or not. So I would strongly consider repeating it because of the very, very long grayscale gives me a lack of contrast, so it's hard to make out the lung markings. And then the rotation is significant. But if this baby was getting serial studies, all the anatomy is there and it was able to be windowed level to a bit greater point, then I would probably side with not repeating this, but I would make my adjustments for the next time I completed an x-ray on this baby. Here you see another baby that's obviously in respiratory distress. This patchiness would indicate that they are having some significant lung issues. You can tell right off the bat, anatomy is there. We've got apex to angle, angle to apex. I see off the bat that we have some quantum model. So as I evaluate the technique, I'm going to say my soft tissue detail, bony trabecular pattern, it's not there. So technique-wise alone, this would likely need to be repeated. So I want to see what other improvements I can make as I repeat this. So I'm going to look at the midcoronal plane. I can see this is the left lung. Here is the right lung. I almost have twice as much on the left as the right. That would indicate that my patient's vertebra has been moved toward the right, which would indicate if this was AP that my patient was in an RPO position. Excuse me, I said that incorrectly. If the spine was moved towards the right, my patient would be in an LPO projection. If I come up here, if I could identify, which I really can't, the sternoclavicular, here's a clavicle, so here's an SC joint, and I can't see this one over here, but this one's far, far away. So that would be my patient's right SC joint is away from the vertebra. That would mean I'm in, again, that, hold on a second, I'm sorry. This is my patient's left side. So its left SC joint is away from the vertebra. So that would mean that, again, it's in an LPO, which puts the spine into the right lung field, narrowing that. So LPO, I'm going to correct that, straighten the baby's head, correct them mid-coronal plane. Mid-coronal tilting, I see a clavicle way up here. It's hard for me to identify anterior versus posterior ribs. So I'm going to repeat this exam, correcting the mid-coronal rotation, putting the baby's face facing upward, and correcting our technique. Okay, technical factors. So proper technical factors should be used to demonstrate all of the following. You know, we were looking for lung. I'm not going to go over this too deeply again, but we're looking for penetration, contrast, and intensity on our image to see all of the listed items. We also are evaluating for all of those wonderful legalities. And when we put it all together, what should we see? SC joints are demonstrated without spinal superimposition, or they're equidistant to the spine. T6 is centered to the image. Lungs are symmetrical. Right and left ribs are equal in length. Ribs are horizontal. That's because the infant anatomy. Entire anterior and posterior ribs are superior, upper anterior ribs are superior to posterior ribs. Mandible is out of the x-ray. No soft tissue overlap. Right and left bronchi are centered to the image. Both lungs are included in their entirety, and at least 8 to 9 ribs are seen posteriorly. We have all the legalities there, including fetal facility information, patient information, lead markers. Radiation protection was used, shouldn't be on our film. We have adequate contrast indicating appropriate KVP and mass settings. No model, no artifacts. So let's try this on a couple really quick. Now you might look at this and be very concerned about the size of this newborn's heart. Do recognize that the thymus gland, which we really don't see in adults, is very prominent on newborns, especially neonates. So the fact that they'd have this increased mass in the thymus area is not that concerning. It's going to regress as the fetus ages. So first of all, we'll look at both of these for the anatomical presence. So we have apex to angle, angle to apex, apex to angle, angle to apex. All the anatomy is there on both of them. Okay, so next we're going to compare these. Obviously have very different techniques utilized. I'm looking for soft tissue detail, bony trabecular pattern, adequate penetration, cortical outline. So over here, I absolutely see cortical outline. I see bony trabecular pattern. Soft tissue detail, I feel like I'm missing it. Over here though, I don't have penetration, but I do have a long grayscale. So what I kind of need is something in the middle of the two of these. I want something with a little longer grayscale over here, a little bit brighter, but over here I need something with more penetration and a little more intensity, or a little more dense. So I would adjust both of these techniques if they were not in the exposure index range, and if I wasn't unable to really window level them to an area I wanted. I would check both of these for all the legalities. So patient information, name, date of birth or MR, facility, the date and time of the exam. This one I can see right here that they do have a letter marker on it. They do even mark the SID that they utilize, so that's going to be very helpful. And this one has none of that. So I'm missing some important information here. So you know, the check marks against this one are adding up towards a repeat. Now, if I look at this again, this one has an artifact. That's an issue as well. But I'm going to continue. I'm looking for mid-coronal plane rotation now. Over here, I see an SC joint here. And this one's a little bit harder to follow, but maybe ends right about there. So it looks like it's pretty equidistant to the vertebra. Over here, if I do the same thing, here's SC joint, here's SC joint, it looks pretty equidistant. So this is a nicely positioned coronal plane. This one is rotated slightly with the right SC joint distant to the spinal column, indicating that that patient was in a slightly RPO position. If I look at the patient's chin, their chin is looking that direction, indicating that head might be turning the body that way. So this one's mandible could be raised as well, whereas this one's mandible is in pretty good position. If I look at mid-coronal tilt, I'm looking for the anterior ribs to be superior to the posterior ribs in the superior aspect, and that is what I'm seeing. Here I see anterior rib, and I kind of lose my posterior rib. Oh, here I can see anterior rib and then posterior there. So it does look like we have a little bit, I would say we have a little bit of mid-coronal tilting, which is unlikely since that baby is in supine projection. So more accurately probably is that there's a central ray issue. So mid-sagittal, we look, this one is perpendicular, this one is rotated a little bit. Mid-sagittal tilting, they both look relatively well aligned. When it comes down to it, when I had to make the decision, I would probably, if this one had an adequate exposure index number, I would probably approve this one as a acceptable, although I'm not a huge fan of the elevation of these clavicles. I feel like there was a little bit of an angle. That flatness of the ribs kind of supports that. This one, I actually like the mid-coronal tilt better, but the mid-coronal rotation is bad. I don't like the technique. The mandible is in the image, so it has a few issues that way. So I would probably repeat this one and let this one go as long as the exposure index was in range. Okay, now I am going to actually skip over this child chest because we've talked about all of that, and we are going to take a quick look at an image. Now I'm going to put these images up. You might want to pause and practice evaluating these images as well. I also want you thinking about what kind of pathology may be one or both of these images. I'm going to have you take a quick look at these couple of images and practice your evaluation, working your way through these, and then and see if you find that you're feeling more and more comfortable as we go. Now we're going to talk about a neonate or infant chest lateral. This is going to be really, really similar to your adult. So your mid-coronal plane here is now going to be perpendicular. Your mid-coronal plane tilt would cause the patient to tilt out of alignment with the long axis. So we're looking for mid-coronal plane to be, excuse me, centered and in line with the long axis of the image receptor. Mid-sagittal plane then would be parallel. Mid-sagittal plane tilt, we want to make sure that that mid-sagittal plane stays equidistant so that we don't have tilting of the patient toward our board, which would take our diaphragms either farther out of supine position and also foreshorten the heart and lungs top to bottom. We want to make sure that the shoulders and arms are pulled out of the way, that we're not pushing off of the table or the bucky by having a flappy arm. So we want those shoulders and arms upright above the head, ideally. Head position, we need that the chin elevated. Breathing technique, we want suspended inspiration on the second breath. IR placement should be about an inch above the shoulder. Central ray positioning should be the center of the mid-coronal plane. And then to the mid-chest, depending on the size of the child. So if we look at this, what were we expecting to see? Well, if we have a mid-coronal plane, oh, actually, I'm going to have you guys run through this quickly, and then we'll go over what the book says. So When we finally evaluate our neonate or infant chest, usually with these they're going to be done supine on the table and then rotated into like a lateral decubitus to accomplish this. For this, if we have a correctly positioned mid-coronal rotation, we're going to get posterior ribs superimposed and a sternum in profile. Remember those tricks. If we see heart in front of the sternum, that would mean the left side is rotated forward. Heart and air in front of the sternum, that means right side is rotated forward. Mandible and chin, not in the exposure field. That's determined by head position. Humeral soft tissue, not in the lung field. That's arm position. Mid-coronal plane at about T6, centered to the image. That would be our central ray placement. Both lungs visualized in their entirety. That's inclusion of all the anatomy, which is going to be dependent on IR placement as well as central ray placement. Hemidiaphragms form a gentle cephalic curve. If we have an abnormal angle, it can flatten or create enhanced appearing curves. So if we were to be angling caudally, that would flatten the curve. If we were to be angling cephalically, that would enhance the curve. And then, of course, all of our legal considerations. So taking a look here at our lateral chest, this says it is a left lateral. It's just hung as a right or displayed as a right. So we're going to first look at our anatomy. So do I have apex to diaphragm, or apex to costophrenic angle, back to apex? So we have the anatomy there. We're a little bit excessive on the anatomy. That tells us our collimation should have been brought up somewhat. Then we're going to look at our technique. So we're looking for soft tissue detail, bony trabecular pattern, and adequate tissue penetration. Our thickest area of tissue is going to be up here in the apex. We see that we are penetrated through that area, so penetration is good. Grayscale is demonstrating lung markings. It's a longer grayscale, so our grayscale is good. But if we look down here, we can almost detect some quantum model. And as well as up here. So I think it would be prudent to increase or double the mass. So we have, if the exposure index, so this would probably be repeatable based off of technique. However, if it was something you felt like they're really focusing on the lungs and the physician could window and level, and I don't want to expose this infant to additional radiation, you could make a case for passing this because it's a technique issue. So if we go on to further evaluate, we're looking for posterior rib superimposition, and you can see here are the vertebral bodies, and you see a rib coming there, a rib coming here, and we have perfect superimposition most of the way up. This little baby has something kind of interesting in the spine there, if you see. It might have something called a hemivertebra. So we have that good superimposition. That tells us that our mid-coronal plane is really pretty perpendicular. If we come up here and look at the sternum, we see that both sides of the sternum are superimposed. So we get it in nice profile. I don't see any heart or any air in front of that sternum. So again, our mid-coronal plane checks out. If we look for mid-coronal plane tilting, that would just mean that the infant is, kind of not in alignment with the long axis of the IR. It looks like we're pretty well lined up, so our mid-coronal tilting looks good. Our mid-sagittal plane tilting would take our hemidiaphragms out of near superimposition. So here they are, about a quarter to a half inch apart, so they're pretty well superimposed. Arms are up here, pulled out of the way. With no superimposition of the humerus or the humeral soft tissue into the lung field, so that looks pretty good. So for this exam, I would, a couple other things, we see that there's a left marker, it looks digital to me, so that is going to affect the legalities. Hopefully this is just anonymized and all the legalities are there. You could certainly make a case for this in being approved as probably a suboptimal but acceptable exam because of the patient's young age, if you felt like the lungs were penetrated enough and the EI was relatively close to the acceptable range. If it was way out of the acceptable range and I'm seeing quantum model, then you definitely need to repeat this based on technique alone and letter marker. Otherwise, the positioning of the exam looks pretty good. Just make sure that you're going to collimate better next time. With that, I'm going to leave you to evaluate the second one by yourself. Hopefully, just a couple quick notes. Hopefully, you're going to see that they have way undercollimated here, so this baby's genitals are nearly exposed when they don't need to be. You'll also see that they have some umbilical artery catheters coming in here and an endotracheal tube. So look at some of that and go ahead and run through your evaluation on this particular image. You may have to pause. Okay, so like we said, for the child's lateral chest, we really have basically the same thing as our adult and our infant chest, just very slight differences. Really, with the child chest, this can range from a toddler to, a teenager. So, so we're going to have to adjust our central replacement. We might have to adjust our image receptor placement based upon the patient's size. Okay, so here we have a couple more lateral chest x-rays, so we can go relatively quickly since you've had quite a bit of practice at this. So here we are, we've got 2 chest x-rays. We're going to start out and make sure all of the non-negotiables are there to see what we need to proceed to. So here we're looking at anatomy. We have our apex, apex to angle to angle to apex. All the anatomy is there. We're going to check the legalities right off the bat. We see we have a digital marker. That is not great, but we're going to check the other legal components. I'm not going to go over those one again, but we're going to go ahead and go with our technique evaluation. So do I have penetration of the diaphragm? Do I have soft tissue detail, bony trabecular pattern, good cortical outline? And I would say, yes, I really do have all of those things. Do I have a long enough grayscale to give me good lung markings? And it looks like overall, yes. So technique-wise, we look okay. Anatomy-wise, we look okay. Legality-wise, we look okay, except for this digital marker. Now we can go to our mid-coronal plane. We're looking for our mid-coronal plane to be perpendicular. We're going to evaluate that by looking at the posterior rib superimposition. We are definitely under a 1/2 inch of separation between our posterior ribs. We have them right here and here. That looks like a fantastic positioning there. We're also going to go and we're going to look at the sternum. The sternum looks in profile. I do not see any heart shadow anterior to it. I don't see any lungs anterior to it, so indicating that we have a good mid-coronal plane here. Mid-sagittal plane then is also good, so we're going to go ahead and skip to our mid-coronal tilt. If I had a bad mid-coronal tilt, we would see the patient across our image like this. We do not see that. They seem pretty vertical, so we know that mid-coronal is in line with the long axis of the IR, so that's a good thing. Passes another check. Then we have to think about our mid-sagittal tilt. Mid-sagittal tilt, we are expecting to see the 2 diaphragms superimpose within a 1/2 inch of each other, and here they are superimposing, indicating that there was no significant mid-sagittal tilt. And then we see up here, no chin in the image. We see arms out of the way, no humeral soft tissue covering the lung field, so everything looks good there. We could have maybe moved our image receptor up slightly and collimated a little bit more, but otherwise a pretty nice image. So that one I would certainly approve. It's right on the border. If it had a good marker on it and a little more collimation, this one would be optimal to me, but because it's missing those 2 little components, I would put this into acceptable. I'll let you do the second one here by yourself, and I'll catch you on the next slide. Okay, so at the risk of not being too redundant on a very redundant lecture, I am going to just draw your attention here. We're doing a neonatal, infant, or child decubitus chest. We already talked about our adult decubitus chest, so I'm just going to highlight a couple things. We're going to make sure that the thoracic vertebra and posterior ribs are seen through the heart and mediastinal structures. That tells us we have adequate penetration. Here's a key one. We need to see an arrow or a word marker to send determining or demonstrating which side is up. Lung field down, we know that we're at risk of clipping that off because if we don't elevate our patient on a sponge, so we need to make sure that we don't have any clipping of the side down. Lung field should be symmetric. Our SC joints, those are going to tell us about our mid-coronal plane being parallel to the IR. Clavicles equidistant to the vertebra, again, mid-coronal plane parallel to the IR. Posterior ribs equal in length, again, mid-coronal plane parallel to the IR. No chest foreshortening would be indicating that there's no mid-coronal plane tilting. Arms, scapula, and mandible are outside of the lung fields, indicating patient's face or chin was elevated and arms were adequately elevated. Upper anterior ribs are demonstrated above the corresponding posterior ribs in infants and neonates because they are anatomically made that way. That was something that we have a repeat of that we saw in the AP infant and neonate chest. Manubrium is superimposed by T4 in older children only. That's going to indicate that there is no mid-coronal tilting, just like because we really have trouble looking at the clavicles at this point to evaluate for mid-coronal tilt because the arms are elevated above the head. Okay, and then all the anatomy is there, and this we're looking for 8 posterior ribs. Everything else is going to be the same. So hopefully that one is going to be a very easy, repetitive evaluation for you to do. Okay, so here we have a couple things to evaluate. So first thing I'm going to draw your attention to is over here. First, we're going to look at anatomy. So I have apex to angle, angle to apex. All the anatomy is there. Secondly, I'm going to look at the legalities. So let's go ahead, and I do not see an upright marker or an up marker, that we should see something like this. And it does look like patient information is flashed right over here, and I do not see a left or a right side marker. So we're missing markers. That is concerning, but it looks like our other legalities are here. What really is catching my eye here is this is ripe with quantum model. So I'm looking for soft tissue detail, bony trabecular pattern, good lung markings, good penetration, good cortical outline. And what I'm seeing is a very high contrast image with no lung markings, telling me that I don't have a long enough grayscale. The other thing I'm seeing is a lot of quantum model telling me I don't have enough mass. So on both respects there, I am very, very low in my technique. I was assumed that the EI values on this would be very low. And so I would need to follow those EI values to make substantive changes to get me to a target EI range. If we look at the more specific, so this is definitely going to be repeatable, but I don't want to repeat it until I know if there's something else that needs to be changed too. So I'm going to come in here and I am going to be looking for spinous processes in the center of the vertebra. I am going to be trying to evaluate those sternoclavicular joints, although it's kind of difficult in this case, and check for them to be equidistant to the spine. I'm having trouble doing that because of the low image quality. So I'm kind of stumped on that one. So I'm going to look at some other things. So if I can't assess that one well, then I know that I can measure my distance between the spine and the lateral rib cage. And if those are equidistant, then I'm probably pretty well. So I probably have a pretty good mid-coronal plane here. We're going to go look then at a number of ribs, because this doesn't look like there's a great inspiration, but let's count to make sure. So I think we have rib 1, 2, 3, 4, 5, 6, 7, 8. Okay, so technically we have the 8 that we need. A little bit more like we see on this side would be nicer, but sometimes we have to deal with patient conditions. So it does not appear that there's a lot of mid-coronal tilt here. The manubrium, from what I can tell, well, it's right in this region, so that would be 1, 2. So the manubrium is a little bit high. The patient does probably seem to be tilting back superiorly. So this is absolutely 100% a repeat. We need markers on here. We need to completely adjust the technique. Positioning is not horrible. They are really close to clipping the side down. So maybe put that patient on a sponge, add your markers, correct your technique, and then position relatively closely, but watch that mid-coronal plane a little bit. This image, you can see, I'm not going to go over the whole thing. I'm just going to let you look at it and practice your technique on there. But what I do want to bring your attention to, we talked about how sometimes hemi-diaphragms work slightly separately. Here's one diaphragm. Here's the other diaphragm. This diaphragm goes much lower than this one. So I just wanted to bring that to your attention. And so then you can go ahead and, it looks like just off the bat, those look like really flattened ribs. That's got to make me think that there's some mid-coronal tilting, but I'm going to let you guys evaluate that image. So I'll catch you on the next slide. Okay, abdomen techniques. So we are finally out of the chest onto the abdomen. The abdomen is relatively easy, so hopefully we can get through this relatively quickly. Abdomen techniques we talk about in class a lot, but we know abdomens are thick. We're going to need a grid. We know that if we're utilizing AEC cells, which is really easy to do on the abdomen, and I think very acceptable, you're going to use all 3 AEC cells at once. You're going to use usually a 40-inch SID, and KVP, if you're on a digital system, probably more in the 80 range. If you are obviously doing different size patients, a neonate, an infant, a child, then of course you are going to adjust accordingly. So KBP of a neonate, you might bring down to 70, 65, infant 65, 70, child 65, 70. If you could get away with it and not have too long of a grayscale, you could go up to 80 just because these are young people and you want to reduce their dose. But that's going to be at your discretion. Okay, a good abdominal technique shows. So what are we looking for here, and how do we know, like, is this a grayscale that's good or bad? Is this penetration good or bad? So what we really want to be able to see is that we want to see good differentiation between the psoas major muscle and fat. So the muscle is going to attenuate slightly more than the fat, and so we really want to see a good outline of that psoas muscle, and that's going to tell us we have a relatively good contrast resolution, so meaning a good grayscale, in order for us to see those tissues that attenuate very, very closely to one another. We also want to be able to differentiate kidneys from fat, and then be able to identify the transverse processes of the lumbar vertebra. With that, it shows if we're able to do that, we're getting relatively good penetration, and we have good enough contrast resolution, a long enough grayscale to see subtleties that we really want to see here. We also learn a lot from gas patterns. So you do not want to overexpose or underexpose so that you can't see gas patterns. The presence or absence of gas and the location can indicate functional, metabolic, and mechanical diseases. So really, a gas pattern can lead you right into a bowel obstruction. The absence of any gas could lead you to a constipation. If you have a lot of gas where you shouldn't have gas, maybe you've had a perforation or an infection. So being able to identify and use appropriate techniques to demonstrate gas is going to be really important. From fat patterns, we learn a few different things. Displaced fat can often indicate that there is some sort of mass effect, and mass effect would mean like there's a mass somewhere moving anatomy that should be in that location. So it's like a displacement of normal anatomy by a mass. We call that mass effect. So here's an example, a couple images of some interesting things. So if you ever forget what the psoas is going to come off laterally of your lumbar spine, and then it travels to your lesser trochanter of your femur. It is going to actually hook up with or connect with what we call the iliacus muscle, which comes off of the iliac crest of your pelvis. So here we have the iliacus muscle off of our iliac crest. It's coming down. We have our psoas muscle coming off of our lumbar. They come together, they join together, and they create the iliopsoas muscle as it goes through your inguinal canal and then attaches to your lesser trochanter of your femur. So we also then are actually trying to see kidneys. It can be challenging to do so, but the idea is we want to see our kidneys. It actually looks like this is a patient with situs inversus. They have the spleen on the right. We know the liver should be on the right, the spleen should be on the left. But so don't look at anything here other than the kidneys. So kidneys, you can see, would be relatively close to, if I added in the psoas muscle, it would be right in this region, and so they're going to be very close, and there's going to be some fat separating it, and so we want good contrast between fat, muscle, and organ. Over here, you can look at this, and you actually see something right off the bat. This is a colostomy. So this circle here would represent basically an attachment for a colostomy bag. So this patient has had bowel surgery, and rather than emptying their bowels through their rectum, now their bowels are emptying through that colostomy bag. Let's see if I can get rid of that now. Okay. The other interesting thing that you're seeing here is that you look at this and think, oh my gosh, what beautiful technique, I see so well. Well, the problem is you're seeing so well because this patient has a pathologic problem. So take a minute and think about what that might be. Okay, you might see that you have a lot of air here, here, here. What we're seeing in this patient is that here's the psoas muscles. We can identify them really well. Very nice. Over here, I can see liver really well. I shouldn't see liver that well. Over here, I can see the spleen really well. I don't usually see the spleen that well. So sometimes when you see things a little too well, you have to be suspicious. Over here, I believe that's probably a kidney. Very small one, but it probably is one. The reason we're seeing this is because this patient has a lot of free air in their abdomen. So it's actually that free air is settling around these organs, allowing us to differentiate between the organs more easily. So we're seeing really well, great image, the tech did a great job, but the problem is that the patient has some pathology. Here we have 3 different images. So we talked about gas patterns, and you can see the significance of gas patterns. Right here, this gas pattern indicates that we have a little bit of gas in the stomach, which is pretty normal. And then we have really a lack of gas everywhere except in the ascending colon. And you will notice in that ascending colon, in between these 2 gas bubbles, we have some pretty impacted or, some pretty constipated looking intestines here. So following those gas patterns, if you're really, really constipated, there's not going to be any gas in that area, but there's some bubbles here. Over here on the transverse and the descending, we don't really see a lot of stool. We don't see a lot of gas, but as you come down here into the rectal area, you see this kind of spongy appearance that would indicate that they've got some stool in their sigmoid rectal area. The one great thing on this image, the technique is actually gorgeous. We have great penetration of these gas patterns. We have beautiful psoas muscles here. You can see the kidneys, which are not always very easy to see. Here you see the lower pole of this kidney. You will recognize that the difference of here is you can actually even see the tip of the liver, which is somewhat uncommon. So probably an ideal patient. You see they have very minimal body fat, but also a fantastic technique. Problem is they miss the pubic symphysis. Okay, over here you're looking at a gas pattern. You can tell by the lack of haustra, we have this really small kind of jagged, I can't think of the correct term, but the small jagged lining to this intestines. That indicates that this is small intestine. You can see that the small intestine is very full of gas, and yet we don't see any gas in the large intestine. So this could indicate that there could be some sort of bowel obstruction here in this region of the small intestine that is preventing that gas from getting into the large intestine and then causing it to dilate more and more. Here you see gas and stool in the ascending. Here's our transverse colon, lots of gas in the transverse colon, little bit of gas in the descending colon. Again, you see a phlebolymph right here and here, like we talked about a couple weeks ago. This looks a little bit underpenetrated. It'd be a lot better if they had a little bit better penetration, a little bit more intensity. Okay, so things we already talked about bowel gas. If we have a patient that looks pregnant because they have so much distension from bowel gas, then we're going to want to decrease our mass or our KBP. If we have a patient with ascites is fluid, so fluid is going to attenuate more than soft tissue. So with ascites, we're going to increase our mass or our KBP. If we have a patient with pendulous breasts, we're going to ask them to get those breasts out of the way. So have them pull them up and out and make sure that they are not in the abdominal field if at all possible. If a patient has a nasogastric tube, that's a tube that you enter, that a physician will place in a patient where they go through the nose with a tube, down the oropharynx, down into the esophagus, and end it right with the tip of the nasogastric tube in the stomach. It is not uncommon for us to get called to do nasogastric tube placements. What you're looking for is to see the tip of that tube, which will appear as a radio-opaque line. We want to see that below the diaphragm. Okay, in order to see that, you're going to have adequate contrast, adequate penetration to really see that tip. A spinal stimulator is a surgical implant into a patient. The implant's underneath the skin with leads, kind of like a, almost like a defibrillator. That those leads go into the spinal canal, and it can provide electrical stimulation, and is supposed to be helpful in pain reduction. So this you might find in the abdomen. Free air in the abdomen is going to be demonstrated best by upright or decubitus position. That patient needs to be in that position for 5 to 20 minutes prior to the exposure, so there's time for the air and the fluid to settle. Body habitus variations are going to require significant technique adjustments. You also may need to change the IR size and orientation. So if you go from a patient that's 5'2" and 100 pounds, you're obviously going to use a vertical 14 by 17. If you go to somebody that's 5'2" and 600 pounds, then you're looking at possibly even going up to from 2 crossways 14 by 17s to maybe even 3 or 4, depending on exactly what the patient anatomy looks like. Okay, upright versus supine, there's a role for both of these, and they're both very important. Anytime that we are looking for free air, which is always, we're going to have that patient upright. And we need to see the entire diaphragm. If you're doing an upright abdomen, to look for free air, you have to see the diaphragm, but you can clip the pubic symphysis if you have to. Supine, we have to see the bladder, but you can clip the diaphragm if you have to. Okay, so we have a focus for each of these. Supine, we're really looking at the kidneys, ureter, bladder. Upright, we're really looking for free air and that the diaphragm is intact. Okay, so we're finally on to the abdomen. So a lot of this is going to have a little bit overlap with chest, so we're going to fly right through this. So our midcoronal plane of the abdomen, we're going to have that parallel to the IR. Our mid-sagittal plane then would be perpendicular. Our midcoronal plane, we don't want any tilting to the IR. Now, sometimes this can be challenging if your patient, say, has a big booty, they're laying down on the table. Obviously, their midcoronal plane is going to tilt. So the best way to approach this is to build them up with some sort of support so that that midcoronal plane can really stay equidistant to the IR. Mid-sagittal plane tilt would indicate that that patient is tilting off of your image receptor, so we want to keep that long axis of the mid-sagittal plane in line with the long axis of the IR. Shoulder and arm positions, these just need to be to the patient's side, above the arms, above the head is fine, but at least to the patient's side. Head position, we're not so interested in that for the abdomen. Breathing technique, you're actually going to want to expose your abdomen on the second full expiration. IR position, if it's a supine, you need the bottom of that IR just distal to the pubic symphysis. If it's an erect, you need it just superior to the diaphragm or at about T10. CR placement is going to be perpendicular, no angulation, and centered to the IR. Okay, so a couple things that we look for. I know this is a little bit different. I'm sorry I deviated from our standard here, but what we're looking at for our midcoronal plane, if we position that midcoronal plane parallel, we should see the spinous processes in the middle of the vertebral body. We should see that the iliac wings are symmetric, and we should see that the sacrum is centered and superior to the pubic symphysis. If my mid-sagittal plane is not rotated, I should see the same things that I did in my midcoronal plane. But if my mid-sagittal plane is tilting, I will be out of long axis with the long axis of the IR. If my CR and collimation and breathing, I need to see T12, the lateral body soft tissue, iliac wings, pubic symphysis, all included on the supine exposure. So we need to see from T12 down through the pubic symphysis. And if I am doing an upright, then I need to see about T9 down to wherever the image receptor ends. Okay, so I apologize here. Please disregard the portable chest. This is for an AP abdomen. So if I positioned all of these, I'm going to have you take a look at this AP abdomen, and I want you looking at exactly what you suspect you will see if you correctly positioned all of these areas. Okay, now one more consideration before we really get into evaluating this is the technical factors. We already talked about how we really want to see that difference in gas pattern. We want to see those soft tissue differences from fat, and those are going to be very important. We also want to make sure that we have good penetration. The way we're going to find if we have good penetration is that we're going to be looking for cortical outlines of the posterior ribs, lumbar vertebra, pelvis, and then gases within the stomach and intestines. On an adult, we want contrast adequate to demonstrate the fat around the psoas muscle and the kidneys and the bony structures of the inferior ribs. Now, the thickest part of our abdomen is typically going to be the larger lumbar vertebra. So if I have to look at that thickest area, the larger lumbar vertebra, and see if I have good penetration where I can see the spinous processes centered to that area, and that will tell me if I have adequate penetration. If I can't see that, then I have probably a KVP, possibly also a mass problem. With children, I'm really looking to see the diaphragm, the bowel, gas patterns, and a faint outline of bulging structures. If I see too much of an outline of bulging structures, I'm going to probably overexpose that patient. The image must include, as you know, all of those legality requirements. Oops, okay, so if we're going to put this all together, like we talked about, we need to take a look at our image and to see how we did. So we're going to look at our spinous processes, and we're going to ask ourselves if they're centered to the vertebral bodies. If they're centered to the vertebral bodies, that means my mid-coronal plane was nice and parallel, meaning my mid-sagittal plane was perpendicular. Are my iliac wings symmetrical? If they are, then my mid-coronal plane was parallel. Now, if they're not symmetrical, they're going to give you some hints. The side down, the side that's in a posterior oblique, is going to be large, where the side elevated is going to be narrowed. So that will tell you which rotation to correct. The lumbar spine should be centered to the image. The sacrum should be centered to the pubic symphysis. So if you think about, if your patient is rotated, the pubic symphysis is going to appear towards the side down, while the coccyx or sacrum is going to appear towards the side up. T12 and the lateral body soft tissues, iliac wings, and pubic symphysis are visualized on our supine, whereas on our erect, our diaphragm domes are located superior to the post-ninth rib. We also need to make sure that we have all of that facility name, patient name, all the legalities, so that we are in good shape there. Now, one of the ways, and I forgot to mention this to you, one of the ways that can be really important when you're trying to position these patients, sometimes it can be difficult to tell if you really have their mid-coronal plane parallel. One of the best ways to do that is to find their ACES and just kind of verify that their ACES is the same distance to the table on one side as it is to the other. The other thing you want to do is sometimes patients will be hesitant to lean flat on their back. They might be rotated. So make sure that you're treating that patient like they are one unit. Legs are extended, hips are parallel to the table, shoulders are parallel to the table, face is straight ahead. And that should, by making sure the ACES are equidistant to the table, is really going to help you master positioning of that mid-coronal plane. Okay, and if you thought it would never come, neither did I, but here we are. Okay, so we thought we'd never get here, but it is our last slide, so we're going to run through the evaluation of these two abdomens, and then we are finally done. So if we look at this abdomen here, we see that number one, we have a digital marker, so we failed our legalities. Hopefully everything else is there, and we might still consider it. Number two, we're going to look at our anatomy. When I look at this, I'm going to say, okay, is this supposed to be an upright? Is it supposed to be a supine? So if it's not marked anywhere on the image, so I'm going to have to guess what they were trying to do. So if I were to guess, I would say, oh, okay, I'm going to come up here. If there's the diaphragm is there, it was an upright. It's not. Oh, then it must be a supine. I come down here. The pubic symphysis has to be on the supine. It's not. So the tech clipped the top and the bottom. Usually a tech's worst nightmare, because now not only do you have to repeat, but you have to repeat at both ends. So this one is going to be need to be repeated, or it is at least going to have like an 8x10 bladder shot added and a crossways image of the diaphragm. So we got some more imaging to do here, but before we do that, let's check everything else and see if we need to correct anything else. So here I see my psoas muscles well. I see outline of the kidney. I see good trabecular pattern here in my ribs. I see the thickest, most densest part of the body has good penetration. We see a spinous process right here through the bony prominence. So technique-wise, great grayscale. We've got good gas pattern. We have very good contrast resolution. So our technique on this was spot on. So now I'm going to go ahead and start looking at the positioning. So in positioning this patient, I am going to see how their mid-coronal plane looks. So if I look here, I can assess a few things based on to assess the mid-coronal plane. First of all, I'm going to see here I got some spinous processes centered to my vertebra. You may notice that the vertebra seems a little crooked here. So I have to ask myself if I position that patient crooked or if they are just a little crooked. So what I see here is that I have spinous processes centered down here, I have spinous processes centered down here, and I have a big curve in the middle. This would indicate that this is probably a scoliosis patient. So I think my mid-coronal plane looks good according to the spinous processes in the vertebra. If I come over here and I look, I can see that I have pretty equidistant between my SI joint and my lateral iliac on both sides. Both iliacs look relatively open. I don't notice a significant difference in size. Usually I'd come down here and I'd look at the coccyx and I'd see if it matched up directly with the pubic symphysis, and that would be key. Since I can't see that, I'm out of that opportunity, and so I'm going to look at these ischial spines. So these are the ischial spines right down here. And when a patient rotates, these are on the posterior aspect of the pelvis, and when the patient rotates, those ischial spines will move posterior to the pelvis or farther out. And because they are really similar in size, this, let's see, it looks like the left one is just a little bit more enlarged than the right. That would indicate that the patient is very slightly rotated into an LPO position. So they're just very slightly rotated to the left, which if I come back up here to these iliac crests, I can kind of buy that. So certainly not repeatable, but just something I could correct if I have to repeat, or if I have to create an additional image to pick up that bladder or pick up the diaphragm. Okay, so then we're going to look at our mid-coronal plane. Was the ACES equidistant to the IR on both sides? So, oh, excuse me, I'm looking at the mid-coronal tilt now. I should see the spinous process in between, in the intervertebral disc space between the lumbar vertebra, and I am finding them there. If my patient was sitting up with their chest elevated, I would see those drop down, oh, excuse me, I would see those migrate upward. If they were, if their butt was elevated, I would see those move downward. So this looks like it has a pretty good mid-coronal, seems to be pretty parallel to the image receptor. Okay, then I'm looking for mid-sagittal rotation. We already looked at that very carefully. We're looking now for mid-coronal, or excuse me, mid-sagittal tilt. I would expect it, if it was tilted, it would be going off at an angle off of my image receptor, but it does look like it's nice and aligned. So I'm going to say this looks good. So the image itself really does look good. It's just they clipped the anatomy, so they're going to have to come back and they're going to have to repeat the two images, or add the two images to help complete this exam. Now, over here on the right, we have a little bit different story. So first thing I'm going to do is I'm going to go and I'm going to look and see if all the anatomy is there. So I have a pubic symphysis, so I'm going to assume that this is a supine. Okay, so supine, got the pubic symphysis. The IR goes as high as it can and include that pubic symphysis, so we're good there. So technique-wise, I'm looking here. It looks a lot different than our other image, but the patient has some different stuff going on. This is a much higher contrast image, but I do see the psoas muscles here and here. I can see a kidney here. I can absolutely see gas pattern here. So maybe part of it is what's appearing differently here is that it is a different gas pattern. I can also see liver here. So really, if I look at it, my contrast resolution is pretty phenomenal on this, even though at first glance it didn't look that great. I'm going to look at soft tissue detail, bony trabecular pattern. We kind of looked at the soft tissue details. So now let's look at the bony trabecular pattern, and I have good penetration through the thickest part. I do have good cortical outline. We have trabecular pattern, but one thing I'm thinking on this patient is they do not have the same kind of bone density that the patient on the left has. And so that's why, again, it's looking a little bit more contrasty, but it's because of the patient as much as it is because of the image. So you can see, actually, this is, unfortunately, somebody did not anonymize this image. I think it's fake information, but it's not anonymized, so patient information is there. They do have a letter marker on. Finally, we have a letter marker, a real one. So legality-wise, this looks pretty good. Anatomy-wise, it looks good. Technique-wise, it looks pretty good. So we're going to go on and we're going to evaluate the positioning. So the positioning now, we're going to look at that mid-coronal plane. So I am going to come directly to the iliacs, and from SI to iliac, I feel like the left iliac is broader. That would indicate that the patient is slightly into an LPO projection. Now, usually I'd come in here and I would be able to easily see the coccyx, but because this patient has a big bowel movement in their rectum, it's going to be really hard to see that. So I'm not going to be able to evaluate that one, but I can still try and come look at those ischial spines. Here I see a spine. Here I see a spine. They look relatively symmetric. So really the mid-coronal here and the pelvis looks pretty good. We're going to follow those spinous processes up the lumbar, and they look good low, but as we get towards the top, I'm seeing them move a little bit. So that in the pelvis, they're a tiny bit LPO. As we go up to the shoulders, if my spinous processes are moving to the patient's left, that would be that my patient is slightly RPO. So their shoulders and their hips are not acting as one singular unit. We have a little bit of RPO rotation of the shoulder, a little bit LPO rotation of the hips, but overall, nothing very significant. So that would take it out of the, that would take it into the acceptable phase. Now we're going to look at the mid-coronal tilt. Here, we're looking for any foreshortening. We're looking for that position of the spinous processes in between the intervertebral disc spaces, and we are seeing that consistently. So it appears really that we don't have foreshortening. Although, if you look down here a little bit at the obturator foramen, those are very foreshortened. So we might have a little bit of an angulation issue here of the pelvis. So it might be that they are raising their pelvis off of the table, closing up that those obturator foramen. So that is kind of an interesting finding. So mid-coronal tilt looks like we do actually have some, mostly in the pelvis, that is affecting it. Now, I'd have to take a real close look at this patient and see if that's what they seem to be doing. I might repeat it if they could correct that. If they're holding themselves that way because of pain, then everything else is so good on this image, I might just let it go. So you'll also see a couple little phlebolyths here down in the pelvis, but pretty decent exam. So I wouldn't repeat it unless I really felt I could get some improvement in that mid-coronal plane tilt. Mid-sagittal plane looks nice and aligned with the long axis of the IR, so I think we're good there. Okay, I know this was a marathon. I hope it is helpful. If I can do anything to help, I would be glad to, so just let me know. We'll get this posted as quick as possible, and have a wonderful day. Bye.